facing challenges on the death notification information, particularly on the part of medical certificate. We are not getting the actual information on what causes the death, that deceased. Last year, December to January this year, we finalized the document and we managed to insert the part of death notification, death certification in the curriculum of the ordinary diploma and the advanced diploma in the clinical medicine.
Tanzania has over 4,500 doctors practicing out there, and as you know, that's a big number just to train all of them, and we had to come up with a much more easier way to reach out to them, and I think collectively, and this is my analysis of the whole scenario, is the more we have the universities being aware and teaching medical certification, I think there will be a lot of awareness coming back to the people who are practicing and creating interest to learn.
So we have been with more than 100 teaching staff, with representing more than 60 colleges. So we're sure now from at the end of this year we will have the graduates from school who know exactly how to write medical certificate of cause of death. And now we are working on the group of universities. As we say now, we finished with those of the lower level, that is diploma and advanced diploma in there. Even ourselves, we promised maybe after a certain period of time, we may do a quality check to see now, after having the graduate who know exactly how to fill a medical certificate of cause of death, how quality a certificate now we are getting.
And this is new, and it's being piloted, and it's part of what we've been waiting. There's a new law that has been drafted. There's a bill in the parliament, and I think there was a go-ahead given that to start learning from the process as the law gets approved. But already there are about 66 pilots, around 60 pilot hospitals where registration has been 66, where now they are doing registration right in the facility. And the idea was to break the barrier which we observed when we did the initial process mapping, that a lot of it was notifications issued, no registration happening. I think we'll see a lot of change now as we get the registration happening right at the place of occurrence of the event.
And very encouraging to hear the curriculum development that you've been doing. Very encouraging to hear the curriculum development. That's fantastic work. It will make a big difference in the future.
We expect so, because we may have a big number of clinicians who know exactly from their colleges now how to handle the mortality information.
Maybe you may want to mention about the in-service physicians who are already out of school. How have you addressed the question of improving their skills in medical certification?
We trained about 2 clinicians at each district, and we went around all region. We grouped them into zone, and we managed to train about it was 2 clinicians for each district. But most of them, they say, look, we have very big number of clinicians per district, so even if you are training us in order to train others, the journey will be too long. But we made it, and then when we insisted them, you have to go and start while we are looking for another initiative. Now the gap is with the rest of the in-service who are still practicing, but they have got no that knowledge, because those who came in that training in between 16 and 17, they said really these things is new as they did during their time at the college and university. They are really appreciated, and they promised to bring the changes even if there were very few. But we have the curriculum now for colleges, and we're expecting to have another one for universities. And those remaining group, they still to be brushed on that. at least to have now a clear picture to everybody who is practicing in the hospitals.
And one of the direct outcomes of what you just described is the anaconda analysis. When you compare 2016 and 2017, there are less garbage calls than it was in 2016. And you can see some trajectory.
Even bigger jump.
But are you planning also to do individual analyses of the coders, of the certifiers, the actual forms themselves, to see how well they're filled in?
Yeah, during our discussion, we also discussed about that, of making analysis, like something like a quality review to see the outcomes of the form.
There is a tool available for that, to assess each form.
Yeah.
I want to be part of that. How many deaths do you do anaconda on now, roughly? What, when you say you're planning on 2016, 2017, what's the number of deaths we're talking about? In-facility deaths.
Was it 27,000?
27,000 last year, which came out of the DHS2.
Yeah. So do you think this would lead to a doubling? You've got 27,000. So with these big referral 14 hospitals, you probably get more than 50,000 deaths through the DHIS2.
I think that was one of the issues we had when we looked at the numbers of deaths. And it was pretty small compared to what we would have expected coming from the hospitals, and we realized actually all specialized hospitals, cancer center, NENIT, those big hospitals where you expect deaths to occur, they were not really hooked to DHS2. And actually I'm hearing for the first time, I'm really impressed that that has taken place, because we were discussing it last year. How can we get the major hospitals where really deaths occur reporting to DHS2? Then this is going to double these numbers.
So, in short, the system are working properly, and we are still receiving appreciation notes from a big number of community. And even last week I discussed with one of the principal of one of the medical colleges school. They said they are happy with the document that we developed, and they are using it. That's where we are to the moment.